Yeah.
अगर साल्मोनेला तो नहीं है, बिकॉज कुछ समझ में नहीं आता तभी also presents like this.
Yeah. तो फाइनली क्या उन्होंने बोला है, बोलो।
सर वो क्लिनिक इन्फेक्शन के उन्होंने दिया है, the majority of patient with clinic infection present with pain in the left upper quadrant or left flank or both, although a surprising percentage of
Yes.
patients are asymptomatic. The majority of patients
Yeah.
with clinic infection have elevated LDH level and about a quarter of them have fever and chills. Some patients of clinic infection with
Yes.
an infectious cause such as EBV, and understanding that infectious mononucleosis has been associated with clinic infarct should prompt repeated or more sensitive testing for mononucleosis before alternative diagnoses are pursued.
So this patient also had that cherry red rash for 1 day. वो उनके हिस्ट्री में उन्होंने बोला था बीच में।
हाँ, बराबर
1 day के लिए उनको था वो cherry red rash.
Okay. ठीक है. So this is a learning for me. I also didn't know this, that EBV can cause splenic infarcts. Huh? The other things what we thought of were correct. Endocarditis, salmonella, melioidosis, all these can also cause. Okay. Sickle cell, autoimmune, ये सब बराबर है.
उन्होंने कंसेस करके एक पैराग्राफ में वो सब समराइज किया, वो पढ़ लेते हो थोड़ा.
हाँ, बोलो.
If the diagnosis is infectious mononucleosis, does this account for the other feature of this patient illness? Elevation of aminotransferase level occur in 50 to 80% of patients with mononucleosis and in up to 3% of patients with hemolytic anemia. In one series, anticardiolipin antibodies noted in this patient were detected in the serum of 30% of patients with infectious mononucleosis. Furthermore, splenic infection have been associated with anticardiolipin antibodies and infectious mononucleosis. Diagnosing this patient illness is challenging and underscores the importance of appropriately framing the most prominent feature of the illness, carefully leaving all the images and laboratory data and focusing further testing based diagnosis of greater clinical probability. I think that a diagnosis of infectious mononucleosis could have been made in this case by no later than the third hospital day on the basis of subacute illness in a 30-year-old woman with fever, splenomegaly, lymphadenopathy, hepatitis, and a normal WBC count with evolving lymphocytosis despite the negative heterophil antibody test. Testing for antibodies to EBV-specific viral capsid antigen and EBV nuclear antigen protein should be performed. The presence of IgM antibodies to EBV-specific viral capsid antigen would be diagnostic.
Okay. It's a good case. And we missed it. But have they mentioned the Wilsons in a differential?
DDs of splenic infarct इन्होंने दिया था सर यहाँ पे.
उसमें तो नहीं आएगा.
नहीं. And दूसरा उन्होंने एक दिया है causes of splenomegaly with subacute fever. 2 DDs दिए उन्होंने.
हाँ. Okay. उस splenomegaly with subacute fever में क्या क्या आएगा?
Sir, headline subheadings of infection, inflammation, and malignancies. In infection, viral, hepatitis, infectious mononucleosis, CMV, HIV. Bacterial, salmonella, brucella, pyogenic abscess, endocarditis. Mycobacterial, TB, atypical mycobacterial infection. Parasitic, malaria, toxoplasmosis, rickettsial, Rocky Mountain spotted fever, fungal histoplasmosis. In inflammation, they have mentioned SLE, rheumatoid arthritis, sarcoid, and serum sickness. In malignancies, lymphomas, acute and chronic leukemias, and other hematological disorders.
Okay. Okay. ठीक है. So आराम से पढ़ो पूरा डिफरेंशियल. हाँ, तो उसमें काफी सारे आपको अलग अलग चीजों का मिलेगा. प्रेजेंटेशन एंड डिफरेंशिएशन. ओके.
Yes sir.
ठीक. हाँ. दूसरा केस करो कोई. तेरा वाला कर चलेगा. हाँ.
Sir, a 16-year-old girl was seen in the emergency department of the hospital because of confusion, anemia, and thrombocytopenia. The patient had a history of lupus nephritis but had been well until approximately 7 days before the admission, when malaise had developed along with frontal headache, lightheadedness while rising, fatigue, palpitations, and shortness of breath. Episodes of nausea and vomiting occurred that prompted her to leave school early. 2 days before the admission, she saw her primary physician. The examination was reported normal and no lab tests were performed. And these symptoms were attributed to a recent tapering of her doses of steroids and stress associated with school. So these are the symptoms 7 days back. And at approximately 9:30 p.m. on the night of admission, right-sided weakness and numbness involving the face, limbs, and abdomen suddenly developed. The patient's parents took her to the emergency room at another hospital, arriving at 11 p.m. On examination, patient was awake, appeared in distress and moaning. She reported abdominal pain. Temperature was 38.4 degrees Celsius. Blood pressure was 109 by 56. Pulse was 98 beats per minute. Respiratory rate 18 and oxygen saturation normal at room air. The oral mucous membranes were dry. Strength in the right arm was reported decreased and gait was unsteady. The examination was otherwise normal. The levels of tropi, creatine kinase isoenzymes were normal, and urine analysis showed 1 plus protein, and ECG done was normal. CT of the head without administration of contrast was normal. So she was started on hydromorphone, metoclopramide, ondansetron, and normal saline were administered IV. During the next 2 hours, the patient reported numbness extended to involving the left side, and increasing confusion and agitation developed. Approximately 2.5 hours after arrival to the hospital, she was transferred to emergency department at this hospital, arriving 40 minutes later. The patient had not had fevers, chills, diarrhea, rash, cough, or nasal congestion or discharge. A diagnosis of lupus had been made 3 years earlier when proteinuria and hypertension had developed after initiation of her OC pills for dysmenorrhea and did not resolve after discontinuation of her medication. A renal biopsy was performed at that time, which showed immune complex glomerulonephritis. The ESR at that time was 49, and ANA was high at 1 is to 1,280 dilution, and with a speckled pattern. And tests for double-stranded DNA was also positive at 1 is to 20 dilution, which was high. And she was started on mycophenolate mofetil, and prednisone was administered, which caused improvement in her proteinuria, and ESR also dropped down to 13 at that time. After a routine follow-up of 2.5 months before the admission, ANA was also decreased to 1 is to 40 and 1 is to 160 dilutions, and in a speckled pattern. And antibody to dsDNA was also positive at 1 is to 40 dilution. So they started tapering the doses of prednisone gradually over a period of 6 weeks from 10 milligrams daily to 10 milligrams alternate day. The patient was born by cesarean section after full-term gestation and
We'll stop here.
Yes, sir.
So this is a young lady, known case of SLE.
Yes, sir.
With lupus nephritis. And proven glomerulonephritis on kidney biopsy.
Yes, sir.
And that also is a complex type of glomerulonephritis.
Yes, sir.
Also, she has dsDNA positive. And she was on the steroids and mycophenolate for the same thing.
Yes, sir.
Now, on the during the phase of tapering these things, she has now come with a neurologic syndrome, which includes focal deficits, altered behavior,
yes, sir.
fever bhi hai na?
Haan, sir, fever.
And also she's having anemia and thrombocytopenia.
Yes, sir.
Barabar?
Yes, sir.
Correct? So, in a lupus patient, when you are tapering the immune suppressants, and patient comes with some symptoms. Barabar. So your first diagnosis is always like a flare,
CNS.
because lupus can cause anything to any part of the body.
Yes, sir.
कोई भी symptom patient के आएगा when during the tapering phase of the steroid, you will end up thinking, is it a flare?
Yes, sir.
Barabar. So now this patient may be having a CNS flare and a autoimmune flare. Barabar. So autoimmune hemolytic anemia, autoimmune thrombocytopenia is a well-described part of lupus.
Yes, sir.
बराबर. SLE में तो होता है वो सब. हाँ, एवान सिंड्रोम बोलते हैं ना उसको, एवान सिंड्रोम, AWAN. When the white count is normal, but the anemia and thrombocytopenia is a autoimmune type. Barabar. Now, other thing I want to point out here is that, like we discussed in the previous case, that all types of autoimmune disorders can fall into 4 groups by mechanism.
Yes,
Type
sir.
1, type 3, type 4 hypersensitivity. Barabar.
Yes, sir.
So type 1 is a immediate hypersensitivity, IgE mediated. Type 2 is a antibody against antigen, and that itself is a main mechanism causing problem. Third is the immune complex deposition into tissues, which is causing the problem. And fourth is the type 4 hypersensitivity, which is cell mediated, which will usually form granulomas.
Yes,
Barabar.
sir.
And we also discussed that the treatment is kind of similar to the mechanism.
Yes, sir.
So like type 2 mates mainly the antibody, which is the problem. So removal of antibody is the main treatment. So
Yes.
from the various mechanisms, we have three of the main mechanisms for removal of antibody are plasmapheresis and IVIG. Rituximab. Because rituximab acts against the CD20, which is associated with B cells. So B cells are the main ones responsible for the antibody production.
Yes, sir.
बराबर. सब जब प्योरली एंटीबॉडी मीडिएटेड कुछ है तो प्लाज्माफेरेसिस, आईवीआईजी, रिटुक्सिमैब ज्यादा काम आते हैं. बराबर. इम्यून कॉम्प्लेक्स डिपोजिशन है तो not much we can do because एंटीबॉडी निकाल के कोई फायदा नहीं है. Already antibody is bound to the antigen and then deposited into the tissue. Now whatever circulating antibodies are there, they may not be the problem. So removal may not help.
Yes, sir.
बराबर. Then type 4 may be said mainly it is a TNF mediated thing. So anti-TNF agents work very well. So all your infliximab, etanercept, steroids, and cyclophosphamide, and all those things work well. Barabar?
Yes, sir.
But now you have to understand that sometimes, rarely, in one disease there may be different types of hypersensitivity. Barabar. So in a lupus patient, the hemolytic anemia is type 2 mediated. But the lupus nephritis may be type 3.
Type 3 mediated.
So both are acting in lupus in certain situations. Immune complex deposition bhi ho raha hai. Antibody is also acting against antigen. And sometimes, rarely, some other types of hypersensitivity will also come into the picture. Barabar?
Yes, sir.
So just keep that in mind that so usually in such a situation, your first differential would be that the SLE has flared up again after the tapering of the steroid. And this may be a CNS flare with the autoimmune hemolytic anemia and autoimmune thrombocytopenia. But इसमें क्या है ना, trap ये होता है कि every time any patient who is suffering from some autoimmune disease, and when you taper the immune suppressant, the first thing you'll think of is a flare. But it need not always be a flare. बराबर.
Yes,
So
sir.
don't keep your mind closed to that. पहले अपने को वही लगेगा because autoimmune diseases can present in any fashion. But keep in mind that there is a possibility of infection. Because even though right now you're tapering, but उसका previous how many weeks, how many months उसने immune suppressants लिया है, that may predispose her to infection, na?
Yes, sir.
So we have to keep in mind infection, especially other things also possible, nutritional and this kind of things, neoplastic and वो सब चीजें भी आ सकते हैं. तो always keep that in mind. ठीक है? So first differential is in this case, of course, SLE flare. But we keep in mind infections. There may be some sort of sepsis may be happening or meningoencephalitis may be happening. We don't know. This patient has been on steroids for a long time and has come with fever and a focal neurological deficit. There can be a brain abscess. Correct?
Yes, sir.
There can be meningitis, meningoencephalitis. There may be a cryptococoma. बराबर को बहुत कुछ हो सकता है ना. नोकार्डिया हो सकता है. लॉन्ग स्टैंडिंग स्टेरॉइड्स लिया है. Patient comes with a neurologic syndrome and some lung findings. So nocardia is another possibility. बराबर. So keep this in mind. Don't get blinkered into one thing.
Yes, sir.
Okay. ठीक है. तुम आगे बढ़ो.
So she had obesity, dysmenorrhea, and right ovarian simple cyst, and had tracheomalacia as a toddler. Her regular medications include mycophenolate mofetil 1000 milligram twice daily, prednisolone 10 milligrams every other day, enalapril 10 milligrams twice daily, norethindrone 0.35 milligrams daily, and ergocalciferol 4000 units daily. She has an African American ancestry and lives with her adopted parents and has an adopted sibling. She was a good student and no addictions or any illicit drug use. Her biological mother's family had diabetes mellitus and hypertension. In the emergency department, vital signs and oxygen were normal. On examination, the patient's mental status alternated between somnolent and agitated. She opened her eyes in response to voice and touch, and she did not make eye contact or respond to questions. She moaned frequently and she occasionally called for her parents. She showed purposeful and symmetric limb movements in response to stimuli. Neuroexamination was limited because of her mental status, but no focal abnormalities were detected. The rest of physical examination was normal. Levels of electrolyte, calcium, phosphorus, magnesium, total protein, albumin, globulin, amylase, lipase, anticardiolipin antibodies, fibrinogen, and CRP were normal, as were tests of renal function. The results of ANA and antibodies to dsDNA were unchanged, and testing for lupus anticoagulant and toxicology screening of blood and urine was negative. The other lab test results showed.
रुको. So now some labs have come. So
Yes,
now what are you thinking?
so for her altered mental status, she can have a mental status. maybe labs देखना है.
या अभी तक जो लैब्स आए उसमें से बोलो ना. अभी क्या बोला तूने? CRP is normal.
CRP is normal, so infective
Auto antibodies are at the
uh,
same level as they were previously.
yes sir, previously 6 weeks
ये
before.
दोनों बहुत वाइटल इंफॉर्मेशन है ना. बोलो ना, इसका क्या मतलब है?
Flare becomes a less likely diagnosis here.
एग्जैक्टली. CRP नॉर्मल है तो कैसे फ्लेयर बोल सकते हैं ना उसको.
Yes sir.
SLE flare becomes extremely unusual for CRP to be normal in a
Yes sir.
SLE flare. बराबर. Same way auto antibodies are at the level at which they started tapering the medicine.
Yes sir.
बराबर. So
Yes, sir.
if it was really a flare, they would have increased.
Yes sir.
बराबर. So this is making the flare less likely. Infection kind of less likely because CRP is normal. Of course, you can have localized infections with a normal CRP, like a foot infection or sometimes even more dangerous localized infection may have a normal CRP. We don't completely rule out infection, but systemic sepsis and all kind of gets ruled out if a normal CRP. The endocarditis gets ruled out. Endocarditis is another possibility in this patient. Na?
Yes.
Patient has been on steroids. Patient has come with fever and a neurologic deficit. So endocarditis is possible. बट अभी सीआरपी नॉर्मल बोल दिया तो थोड़ा मुश्किल है। हाँ, ठीक है। सो what we may be dealing with is something which is not flare and not infection. So actually, then it becomes very difficult to explain any of these features, but it's possible. And like maybe there's a drug toxicity in some strange way. ठीक है। you तुम लोग को सबको डायग्नोसिस मालूम है क्या? किसी को? अभिषेक को मालूम है?
नहीं पता है सर इसका ये।
मुझे पता है।
सबको मालूम है? इसको नहीं मालूम, वैष्णवी को नहीं मालूम।
हाँ, उसको
वो तो चलेगी।
वो
तो हाँ, मेरे को अभिषेक ने बता दिया डायग्नोसिस, तो एक्चुअली मैं उसको बोला कि मुझे कभी बताना मत, आई नो द डायग्नोसिस, बट स्टिल वी आर ट्राइंग टू डिस्कस बिकॉज दिस इज हाउ यू हैव टू थिंक अबाउट इट। ठीक है। सो दैट एक्चुअली फिट्स दिस, टीटीपी फिट्स दिस बिकॉज that is neither infective nor inflammatory. It is just a mechanical microvascular microangiopathy. बराबर? So this was the clue to that kind of pathology. आगे बढ़ो। हाँ।
Sir, her labs showed on the day of admission, HB was 7.9. Sorry, on admission to this hospital, her HB was 6.8. Reticulocytes were 20.8. White cell counts of 10,500. Neutrophils 86. Lymphocytes 10. Monocytes 4. Platelet counts of 16,000. On smear, there was 2 plus anisocytosis, 1 plus polychromasia, 1 plus cystocytes, and basophilic stippling present. ESR was 45, haptoglobin was less than 6, the normal range being 16 to 199. D dimer was 3508, normal range being less than 500. Fibrinogen was 368, which was normal. And creatinine and glucose and urea nitrogen were normal, sir.
हाँ सुसी, इसमें अभी क्लूज ये आए हैं कि शिस्टोसाइट्स दिख गए उनको।
यस सर।
बराबर। दूसरा क्या बोले वो?
Haptoglobin
हेप्टोग्लोबिन
less
कम
than
है।
6.
देयर इज
Yes,
अ
sir.
इंट्रावैस्कुलर hemoglobin hemolysis happening. बराबर।
Yes,
In an
sir.
extravascular hemolysis, haptoglobin will not fall.
Yes, sir.
बराबर। So this was the clue. So hemolysis में इंट्रावैस्कुलर एक्स्ट्रावैस्कुलर होता है।
Yes, sir.
बराबर। तो इस तरह डिफरेंशिएट करते हैं, उसके अलग अलग कॉजेज है। हेमोलिसिस पढ़ लो बराबर से, इंटरेस्टिंग भी है, पूछते भी है।
Yes, sir.
ठीक है। देन द अदर हिंट इज दैट डी डाइमर इज हाई बट फाइब्रिनोजन इज नॉर्मल,
Normal.
सो दैट गोज अगेंस्ट। सो अनदर डिफरेंशियल इज डीआईसी।
I see.
टीटीपी के लिए डिफरेंशियल इज डीआईसी, बराबर, बिकॉज एनीमिया, थ्रोम्बोसाइटोपेनिया, कंजम्पटिव कोआगुलोपैथी होता है ना।
Yes, sir.
So the thing that goes against DIC in this patient is the fact that probably the PTINR will also come normal.
Normal. Yes, sir.
Yeah.
Normal.
PTINR normal, fibrinogen normal,
Yes, sir.
but high D dimer and anemia, thrombocytopenia and vascular events are happening.
Yes, sir.
बराबर? So this is the clue and main differentiator between DIC and TTP.
TTP. Yes, sir.
Okay, so now it fits into TTP perfectly. There's a
Yes,
hemolytic anemia happening, which is an intravascular hemolysis. There is a thrombocytopenia, there is a fever, and there is a neurologic syndrome.
Neurologic symptoms.
The treatment is mainly, it's an antibody-mediated thing, so treatment is plasmapheresis.
Plasmapheresis. Yes, sir.
बराबर?
Yes, sir.
So now, can anybody tell me what is the mechanism of TTP HUS?
Sir,
Yes, sir.
Sir, for TTP, the mechanism is that there is Adam TS13, which cleaves the von Willebrand multimers into monomers. So, if there are multimers, there will be more platelet adhesion and aggregation, which will lead to increased thrombosis. एंड हाँ डेफिशिएंसी रहेगा तभी बड़ा ADAM-TS cleaves the multimers of one Willebrand factor into monomers. Efficiency होगा तो
बेसिकली वॉन विलेब्रेंड फैक्टर कब रिलीज होता
नहीं in response to tissue injury रहता है in response to a tissue injury sir or
है? हाँ, so actually it is in response to some vascular breach
yes sir
और टिश्यू इंजरी.
yes
तो
sir
उसमें क्या होगा, वॉन विलेब्रेंड फैक्टर सब रिलीज हो जाएगा एंड it is supposed to clot at the site of the injury
yes sir
and वो मोनोमर का मल्टीमर का मोनोमर होना मांगता है.
yes
वो
sir
करता है ADAM-TS13.
yes sir
ADAM-TS13 नहीं है तो वो मल्टीमर रह जाता है. तो मल्टीमर रह
yes sir
जाता है तो वो बहुत ही बड़ा रहता है मॉलिक्यूल. एक्चुअली इट्स अ ह्यूज मॉलिक्यूल. बराबर.
yes sir
तो व्हाट हैपेंस इज दैट सब जगह वो बैठ जाते हैं जहाँ पे भी टिश्यू इंजरी है. And all over the vasculature, von Willebrand is sort of swarming like a spider. समझा?
yes sir
So you have to imagine it like this कि बैंड्रावर्ली सीलिंग है ना. बैंड्रावर्ली सीलिंग पे गाड़ी बहुत फास्ट जाते हैं.
yes sir
ये जो गाड़ी है, हाँ, ये they are the RBCs. The road is the blood vessel. बराबर.
yes sir
हाँ, तो अब वो सस्पेंशन ब्रिज के जो रॉड्स है, हाँ, instead of suspending the bridge, they are all over the road in various shape. ठीक है. और अभी फुल स्पीड में गाड़ी वहां पे जाएंगी. अभी आरबीसीज आर ब्लाइंड. तो फुल स्पीड में गाड़ी रोड पे जाएगा तो गाड़ी को क्या होएगा?
accident
टूट जाएगा ना.
हाँ
पीसेस ऑफ द कार विल कीप ब्रेकिंग.
yes sir
तो दैट इज अ शेयरिंग.
okay
तो आरबीसी जब कट जाते हैं तो अलग अलग शेप के दिखने लगते हैं ना.
yes sir
तो उसको हम बोलते हैं क्रीनेटेड आरबीसीज, शिस्टोसाइट्स, हेलमेट सेल.
okay
बराबर. हाँ.
yes
So
sir
this is exactly what happens in the TTP. In the small vessels of the body, RBCs which are going at high speed, they are having a shearing stress on them because of the large von Willebrand factors,
okay
multimeric, which have not been broken down like they should have been by the ADAM-TS13.
yes
तो क्या होगा? हिमोलिटिक एनीमिया हो जाएगा.
sharing
और ये वैस्कुलेचर के अंदर हो रहा है तो इंट्रावैस्कुलर हिमोलिसिस होएगा.
hemoglobin निकलेगा hemoglobin
तो एनीमिया हो जाएगा.
yes
अभी ये सब जो वॉन विलेब्रेंड फैक्टर है, इट अट्रैक्ट्स द प्लेटलेट्स टू इटसेल्फ आल्सो.
yes sir
जहाँ पे भी वॉन विलेब्रेंड है वहां प्लेटलेट भी आके सब बैठ जाते हैं. बराबर. अभी प्लेटलेट्स आर ऑफ लिमिटेड क्वांटिटी है ना. 1.5 to 3.5 lakhs सारे प्लेटलेट ये वॉन विलेब्रेंड के पास जाके मेकआउट करने लगेंगे. तो फिर पेरिफेरल ब्लड में कितना मिलेगा प्लेटलेट? कुछ नहीं मिलेगा.
yes
कंज्यूम हो गया ना. इसे इन अ वे से कंजम्पटिव. फिर जहाँ पे जरूरत है वहां पहुंचेगा नहीं वो.
yes sir
So there can be bleeding then. So now you understand the full mechanism.
yes sir
There is a micro so microangiopathic hemolytic anemia. दूसरा इसको बोलते इट्स लाइक अ माइक्रो इसका एक टर्म याद नहीं आ रहा है मेरे को. एनीवे, बट बेसिकली इट्स अ ट्रॉमेटिक माइक्रोएंजियोपैथिक ट्रॉमेटिक हेमोलाइटिक एनीमिया. ठीक है. बिकॉज़ दिस लाइक अ ट्रॉमा ओनली ना.
yes sir
बराबर. सो इट्स अ माइक्रोएंजियोपैथिक ट्रॉमेटिक हेमोलाइटिक एनीमिया विद थ्रोम्बोसाइटोपिनिया. एंड जहां पे भी ये वॉन विलेब्रेंड और प्लेटलेट बैठे हुए हैं वहां वहां पे वास्कुलर इवेंट्स होंगे ना. जो लिवर हेपेटिक आर्टरी में चला गया तो हेपेटाइटिस होएगा. किडनी में चला गया तो किडनी इन्फाक्ट होएगा. स्प्लीन में गया तो स्प्लीनिक इन्फाक्ट होएगा. ब्रेन में गया तो ब्रेन इन्फाक्ट होएगा. हाँ, but you may not see it on the angiogram because these are micro vessels. बड़े vessels में नहीं होता है ये. तो patient has come with a stroke, but MR angio is normal. ऐसा होता है इसमें. इसको भी ऐसे ही हुआ ना, CT नॉर्मल आया ना इसका, डिस्पाइट
It
अ
was
राइट
normal.
हेमिपेथेसिस.
Yes, sir.
एग्जैक्टली. तो इट्स अ माइक्रो infarct due to microangiopathy, and angiogram and imaging में come normal initially.
Yes, sir.
जब infarct बहुत बड़ा हो गया तो मिलेगा of course. ठीक है.
Yes, sir.
So now you understood completely
Yes,
the
sir.
mechanism.
Yes,
This
sir.
is how it happens. HUS का भी similar है mechanism.
Yes, sir.
ठीक है. Now there is a hereditary disease which also has a microangiopathic traumatic process happening similar way में. उसका नाम क्या है? ये भी हमने किया है डिस्कस बहुत पहले. अपशॉ-शुल्मन. अपशॉ-शुल्मन डिजीज. बराबर. तो जब भी तुम एक कंसेप्ट से 3 डिजीज को एक्सप्लेन